But ultimately, we're going to jump right off in the idea of really a clinical space that's a new space. So I've talked a lot when I was talking to some of the companies that one of the biggest changes we have in cancer is not having a new drug, because that's exciting and that does make a big difference from our patients. But if you change how a disease is defined, meaning you change how you test for it, you change its understanding of its biology, you actually change how the whole spectrum of the disease is understood. So when PSMA scans came out in the last few years, very important, we now can see much more disease than we ever used to, which then means every single other scenario, it's, well, what does the disease look like in this new technology versus this old technology? So how then do we approach these scenarios when every single one of our older clinical trials never included these patients because they didn't have these scans? So we don't have that kind of data. So it really gets to us, which is fun as academicians, where we get to then debate, and of course people think they know the right answer because that's what you do in academics. But the idea of saying that that's something that we can then debate about because, well, what did this patient look like? And that's really what we're going to talk about for this first session. And that's in between. So these are patients that have localized disease and historically would have been called only localized patients. But ultimately then when we do these advanced scans, we actually find stuff that we didn't either see. So we're going to go into that. So I do have disclosures for myself. I've done consulting work for AstraZeneca and Janssen. And then also Bob Dess is going to talk a little bit more when we get to the cases, as then is co-directing for Moxie, and then also an editor then for the Red Journal. So this is the issue. There is no prospective clinical trials for anything that we are discussing here, because what I'm discussing here is patients with known metastases on PSMA-based imaging with normal conventional imaging. These patients all would have gone straight to surgery and or radiation, plus or minus systemic therapy with the radiation, but ultimately would have been managed in a completely different way than we think about when we know that there is disease outside the original organ, which usually we have to approach it with both systemic and localized therapies. So ultimately, being that there's no data, we can't be right or wrong, so that's awesome for us. But ultimately, we have to then rely on what do we do for other cancers? What are the main oncologic principles that we think about when we take care of patients with cancers? My colleagues who work in rare diseases that don't have large clinical trials to tell them what to do every space of the way, they say, yeah, welcome to my life. This is how they have to make decisions in lots of steps. But we really, the first step is, especially in prostate cancer, and these are patients with not a lot of disease, so we want to make sure we're not under-treating them. So we want to make sure we're trying to make sure we're giving therapy that's appropriate for the amount of disease risk that we're seeing. But we also don't want to over-treat them and give them more therapy and more toxicity that we just aren't sure have the long-term benefits and then those long-term risks of those therapies. And then finally, we're going to hit on here is, well, we do use systemic therapies in this space, but how long do patients need to be on them? These are therapies that have very significant quality of life impacts. Hot flashes, stamina, fatigue, sexual dysfunction. These are things that you say, yeah, I can deal with that for 6 months or 3 months, about 2 years. What about 20% of patients that never have it really come back when they're done with systemic therapy? Those are worries then for patients, and we have to figure out for these patients that we would now define as maybe metastatic, what is that right amount of therapy? Those are the things that we're going to, I'd say debate, but since there's, again, no data, we can go crazy. So I think the big first part here is make sure that we're defining the disease correctly. And so what I mean by that is for patients that have PSMA scans, look at the scans, make sure that if you see lymph nodes that are more than 1.5 centimeters in short axis, that is not molecular disease anymore. That's a standard imaging positivity. They see a lymph node that is of that size historically would have been seen also. So these are not the in-betweens. These are patients with metastatic disease by conventional imaging. That is not what we're debating here so much today, because though we're low volume metastatic disease, we have lots of data there. That is a whole nother field that you can look at last year's talks, because I'm pretty sure we covered it then. But ultimately, that we have a lot of data to guide. Then the other part is you want to make sure that what you're seeing, does it actually make sense? So we all are physicians. We all get lots of data comes our way. I had a day the other week, all my patients had low magnesium. I'm like, what's going on? Why does everybody have low magnesium today? That's because the lab had a calibration error in their machine. And I got a call from them later, and they'd been like, sorry about that. All our magnesiums are actually normal. So you want to make sure you're looking at the data saying, does this data make sense for this patient? Does a patient who has a 3+3, 1-core prostate cancer, and I'm going to stay out of defining cancer or not, is that a patient who would have a nodal disease? That doesn't make sense. So we want to make sure that what you're seeing, does it make sense? And then false positives do occur. This is a technology, it's a diagnostic. Yes, it is better than what we've had before. There are also still false positives. So this is where making sure that you've looked at a lot of scans to try to make sure you're comfortable with understanding them as best you can, and also the people reading the scans are good at you and used to looking at these things, because other stuff can show up too. Sarcoidosis, you can get in the neuroganglia, and you can get other things that will also look PSMA positive. So let's start with the systemic therapy, so under treatment. So we think about systemic therapy. Once we know that the prostate cancer is not only in the prostate itself, this treats the disease that we are seeing on that new technology, and also knowing that technology has limitations, this is treating that disease that we can't see. So we know that with radiation and lots of localized studies and even adjuvant studies, if you want to go way back to Messing data, that systemic therapy for patients with metastatic disease is good. Shocking. But really the question becomes is, what are the roles of the extra therapies that we're doing now? So we think about, these are the abiraterone, apalutamide, enzalutamide, and darolutamide, and we're going to, today is not the day to try to debate which of those have different roles in different scenarios. Again, way too much time that would take, but ultimately, these are the things that we consider. For this patient, what is the roles of these? Is it appropriate to be using it for them? And again, all studies with standard imaging have shown that when you've added this therapy to the systemic therapy, it has improved outcomes in regards to usually radiographic progression-free survival at a minimum. And most of those studies, again, in disease that has spread, have also read out as overall survival benefits. So I would sort of say is you should at least go through the thought process for a patient who has disease outside of the prostate on these scans, because ultimately, most of the time we've tested it when we have, it has come back as positive, but we're gonna get into a little bit more of that data in a second. One thing I'd be hesitant to say is the reverse. So historically, we've also had patients that have had surgery, or I'm gonna focus on that a little bit because there's a little more data that way, but had their primary treated and had the disease come back later. So that's called biochemical recurrent prostate cancer. That's a little different disease biology than a patient who we're seeing for the first time already has disease in a lymph node. Now, maybe that person with biochemical recurrent disease had disease in their lymph node when they had their primary therapy, however long ago. Can't go back and answer a question in the past, but the idea of saying that that data is exactly the same to apply here, I'm a little more cautious with that about potentially the overtreatment aspects, because that's just a different disease biology. Because when we're looking at it, this is synchronous metastases, meaning we find cancer in a node at the same time that we have cancer in the primary, as opposed to metacrinous, where you've managed the primary, and then later on, the disease is found in a distal spot. So the two best areas I think we have here, actually looking more at the localized disease setting, looking at the higher risk localized within Stampede, and then also within Enzarad, which just was presented at ESMO this year. Or was it Astro or ESMO? I got mixed them up. ESMO. All right. Good. I don't go to that one either. So Stampede, so let's focus on what are those patients? What are the patients that were in the Stampede M0 cohort? So Stampede therapy was 3 years of systemic therapy with ADT and 2 years of abiraterone. I think we tend to sometimes forget the 3 years of one, 2 of the other, and usually just look at 2. They had to be node positive by CT scan. We're looking at pelvic disease only. So that'd be higher risk than what we're looking at here, because this was standard imaging positive. Or 2 of the 3 criteria with T3, T4, PSA over 40, or Gleason 8, 9, 10, 2 out of those 3. This is a very, very high risk cohort. The idea that these patients, probably many of them, the ones that didn't have node positive disease that we know of, many of these patients probably we would think have positivity on their PSMA scan if they had one, just because that risk is so high. Now that is not a guarantee. We are being very patients that with a PSA over 100 are coming to see medical oncology first. I do have some patients we've done systemic imaging and PSA of 100, 200 still had localized disease. And so there are some rare scenarios that you just need to make sure that you've evaluated them appropriately. And then Enzarad, again, high risk localized, but a different population. So they were 2 years of ADT, 2 years of enzalutamide. They required Gleason 8 out of 10 or Gleason 4+3 with other high-risk features with PSA over 20 or N1 pelvic disease. So not exactly the same Stampede cohort. And then they did stratify by those same things to try to make sure the arms are similar. But again, that is the patients that they were selecting. So we look at these cohorts. This is the overall survival for that M0 Stampede cohort. And you can see clearly that an overall survival benefit over time with a hazard ratio of 0.6. Oh, sorry. So pretty straightforward. And I think, and if you also look at prostate cancer specific survival, because look at the red curve, which is the hormone therapy alone with radiation. At 5 years, you're still at 85% prostate or overall survival. So these patients are doing well, even in the control arm. But if you look at even prostate cancer specific survival, at 6 years, it's 93% for those who got the intensified therapy versus 85% in the single arm. So it does appear that you're affecting prostate cancer mortality and then also overall mortality. So this is then the prostate cancer specific survival. But again, patients can do well. So getting also to what we discussed this morning with bladder cancer, some patients don't need more intensified therapy if they have other comorbidities that you are trying to also manage to make sure you are not worsening. Enzarad, lower risk populations, overall survival didn't appear to be improved. So how do we then rectify these two scenarios? Some could argue that is it the extra year of ADT? Is it the enzalutamide versus abiraterone? We've looked at that in the metastatic space, doesn't seem to be as much different. So then also prostate cancer specific survival is not different between the two. So why? So first off, regional lymph node involvement. Looking at Enzarad, if you start doing subgroup analyses, regional lymph nodes, if you had N1 disease, seems to be improved that the addition of enzalutamide did improve metastasis-free survival, which is a known surrogate for overall survival in this cohort. While if you didn't, it seems to be going to the null. And look at the numbers. So the number, kind of a little blurry, but the number is you're looking at 40 patients in each arm. That's not going to be enough to be definitive. So the idea that again, N1 disease was a subpopulation of this and a small part of it. So this is then head-to-head. What are the population differences between these two studies? PSA over 20. Now, Stampede didn't read out exactly the sort of same criteria, so it's a little median and interquartile ranges. But those with PSA of 20 over, in the Enzarad, it was 36% in the enzalutamide arm. In the median in the Stampede study was 32%. And we're over fit, the median was 32. So that means at least 50% of them were that. So it's much higher PSAs. If you look at T3, T4 designations, 47% in enzalutamide, 94% of patients had T3 or T4. 35% then were positive on conventional imaging in Stampede, while only 12% were in Enzarad. So again, Stampede is a higher risk cohort. So when I sort of put this, I thought Dr. James did an excellent job at ESMO sort of putting it into context. This is a way of looking at the whole prostate cancer spectrum, with the left being intermediate to high risk and on the right being high volume metastatic disease. And you can see Stampede covers some of Enzarad because they do have some overlaps, but Enzarad seems that it includes some slightly lower risk patients as well, and was actually maybe even selected for more of those low risk patients, while Stampede was only higher. And when I kind of think of, well, where do I think PSMA patients are going to fit in? I think they're going to be looking a lot at that Stampede cohort. I do think it's a little outside of it in the idea that I have seen some patients with PSMA disease that looks a little more like Enzarad that has had N1 disease on molecular imaging. I think that's something we're going to have to figure out over time. That hasn't been really gone back and looked at what is exactly in the localized setting. A lot of interest in the metastatic setting, but not localized, but what things are PSMA positive versus negative. And so then we get back to our therapies. What about radiation? Are these patients with small lymph node metastases, should we even be doing radiation to the primary? I'd like to thank Dr. Dess for completing this slide for me, but there's data then from Stampede and from PEACE-1 showing an improvement in radiographic control, symptomatic control with PEACE-1 of doing radiation here. And surgery, and historically could be considered, but with such high risk categories, the likelihood that they will need radiation after surgery to manage the nodal beds is so high. You know, the question would be, is its benefit for the majority? Now, those with significant obstruction, I think that could be revisited because that is a symptomatic gain. So looking again at our kidney discussion this morning, whether you're improving somebody's quantity of life would be debatable, but you might include their quality of life, and maybe that is a margin of benefit there. So what about avoiding overtreatment? So we keep looking at this longitudinally, then, well, what about docetaxel? We use docetaxel in metastatic disease, and if we're saying this is metastatic disease, synchronous metastatic disease, the Stampede cohort, docetaxel was beneficial. I think we have to be cautious because Again, that is much, much higher risk population because it was standard imaging positivity. So let's look at what we have. So the STAMPEDE M0 cohort actually did a docetaxel arm. So standard of care versus standard of care plus docetaxel, M0 with, and look here, this is 460 patients in one arm, 320. So comparing it then to Enzarat, this is a much, much larger number of patients, and that the M0 cohort clearly is closer to 1 and overlapping. And then because of this was also then had an arm with zoledronic acid and docetaxel, some statistic parts they were not able to be combined, but also shows that the M0 component seems to be erring towards the null for docetaxel. There's been other studies looking at it. That STAMPEDE is the one I had mentioned. This is then RTOG 0521 that we participated with at Michigan, with the idea of ADT with radiation plus or minus docetaxel for 6 cycles. This is the criteria then, again, how patients entered the study is critically to understand how patients did at the end. And if you look, yes, the curves look a little bit different, but the hazard ratio clearly overlaps 1 without then an overall survival gain. So this is then looking at lower risk metastatic. So these are patients with metastatic disease on standard imaging, so higher risk than what we are talking about for the patients with molecular, with low volume metastases based on charted criteria. The overall survival benefit tends to wear away in different studies, such that, again, docetaxel really should be reserved maybe for those with clearest, widest metastatic disease with, again, we haven't talked at all about toxicity of docetaxel, which is significant. These are the 2 names of the studies. So what about treating those metastases? I think we're going to be getting a lot into that this afternoon. I'm definitely not the expert on that. Does treating it make sense for the patient? Is it how many sites? I'm going to kind of leave that a lot to the cases that Dr. Dess is going to go over. Heterogeneous population, though. What about somebody who has 1 lymph node? What about 20 lymph nodes? How, is it all in one side? Is it just unilateral? Is it bilateral? How are we defining it? Is it pelvic? Historically, I talk with patients because they always ask, what stage am I, and what does N1 disease mean and such. These were also anatomic stagings from the AGCC. I question their utility in today's world because I think the biology of somebody who has an N1 disease is not that much different biologically than somebody who has one singular metastases elsewhere. But ultimately, that is the staging that we use. And then we're going to try to answer that question in the future with ongoing studies. So duration of hormonal therapy. So this gets to indefinite versus time limited. Looking back in the 90s, indefinite therapy for somebody with metastatic disease was defined as the view of the standard of care. Now with a lot of better therapies and also better understanding of long-term toxicity of these therapies, we're sort of revisiting that discussion, but we just don't have the studies yet to really inform that. So in the in the metachronous setting, we've looked at doing intermittent therapy there. That did show to be similar in Crook et al. So it does seem to be that maybe those with lower risk can do fine with intermittent therapy. And this gets to the idea of the things that I consider when I see a patient. What is their tolerance of the ADT and RP that we started? Because how long you do it does not need to be decided on the day you start. It needs to be decided when you hit those time points, 6 months, 12 months, 18 months, 24. So you'll know tolerance when you get there. The longer duration of therapy, maybe a longer recovery time. Longer duration, also the rate of lack of testosterone recovery rises. So patients who are in the older age also, give an 85-year-old 2 years of hormonal therapy, that may never recover then afterwards. So taking the idea of their ability to recover from the therapy rendered. And then, of course, competing mortality, as we've touched on lots of times. So this is a summary of the things we talked of. For systemic therapy, should be considering an ADT, and I would consider an RP in these patients. I would say there's no role for docetaxel. I would consider radiation to the primary, and then the idea of indefinite versus intermittent therapy, I think, is something to discuss. I tend to think that doing an intermittent therapy is a very reasonable approach for these patients with low volume disease, that we're really looking at them having 5, 8, 10 years of expected survival, that competing mortality risk and toxicity rises with the duration of hormonal therapy. So